Hello, let's learn about antimicrobial stewardship. Then we'll be learning about surgical antimicrobial prophylaxis. The principles of antimicrobial prophylaxis. First is to objective to prevent a surgical site infection, morbidity, and mortality. Optimize the patient's surgical procedure and overall outcomes. Select the ideal agent for prophylaxis and use it in an appropriate way. Work against the pathogens and most likely to contaminate the site with consideration of the resistance patterns. Shorter effective durations, correct administration to ensure optimal concentration. Prophylactic agents should have minimal adverse effects, adverse drug reactions, selection pressure for the resistant organisms, and complications such as C. difficile infections and Canada site infections. The surveillance sprint for surgical site infection should be within 30 days or 90 days as per the procedures, as per CDC guidelines. The contributing factors for the surgical site infection includes pre-operatively, intraoperatively, and post-operatively. Pre-operatively it includes the underlying medical conditions, the diabetes, hypertension, and pre-operative preparations such as scrubs. Intraoperative risk factors are surgical techniques, nature and duration of the procedures, the glycemic control, environmental control, and suboptimal prophylaxis. Now, what are the part of the surgical site infection puzzle? Before surgery, it is the insured patients bath or shower. Do not shave the patients. Only use antibiotics when recommended. Use chlorine alcohol-based antiseptic solution to prepare the skin. Have a surgical scrub technique. Ensure all the surgical equipments are sterile. Limit the number of people entering into the operating room. Do not continue antibiotics to prevent infection. This is unnecessarily and contribute to the spread of resistance. And check the wounds for infection post the operation. So there are the prophylaxis for surgery, surgical prophylaxis. The guidance for surgical prophylaxis needs to be consistent based. The new versions will be expected soon in years, as in the antibiotic therapy guidelines. We have variant surgical prophylaxis for each of the operative surgeries has been mentioned. The Center for Disease Control advocate clean contaminated procedures to do not require antimicrobials after surgical incision is closed. Topical antimicrobials should not be applied to the surgical incision. Time antimicrobials to its maximum concentration in serum or tissues at the incision. You can refer to the CDC guideline for the prevention of surgical site infection 2017 for the same. Organizations can use this slide to highlight their own surgical prophylaxis. Many healthcare settings will not need to develop local guidelines, but it may be so. We have national safety and quality service standards where you can refer to this to the guidelines on antimicrobial stewardship, wherein each healthcare setting or hospital should have an antimicrobial formulary that includes restriction rules and appropriate processes. The health service or the advisory number A17 mentioned that health service organizations should ensure surgical prophylaxis is included and addressed as a part of the stewardship. Auditing the prophylaxis in your health service organization is required, is imperative. Hospital National Antimicrobial Prescription Survey needs to be added, or Surgical National Antimicrobial Prescription Survey, or local audit tools, or monitor the use and surgical inpatient continuously with the inpatient control staff. Local NAPS 2017 guidelines mentioned about a hospital, that is Hospital National Antimicrobial Prescription Survey, is a voluntary survey which is assessed to antimicrobial appropriateness in Australia. On average, 30% of the prophylaxis is extended about 24 hours more beyond the time of the surgery. Private hospitals extended beyond 24 hours were about 27%. Public hospitals were about 37%. Women hospitals nearly 16%. And the southern hospital part it is about 18% of surgical prophylaxis. The local NAPS data on surgical prophylaxis mentions NAPS is a core component of many stewardship programs. Increase open dialogue upon AMS among healthcare professionals, identify gaps, informed guidelines and education material is imperative. Larger hospitals are self-sufficient, but there are some hospitals with total ID support. Motivated and willing, but lack the confidence. Need somebody to talk further advice. The local NAPS data mentioned about more than half of the antibiotic prescribing for certain events in hospital was not consistent with the recommended prescribing practices. Antimicrobial prescription was not supported in 79% of the patients with community acquired pneumonia, 77% of the patients with UTI, 47% of the patients with prescribed fluoroquine treatment, and 27% of patients prescribed IV vancomycin antibiotics. The organization can use the slide to display the local surgical audits from special registries such as the American College of Surgeons and the National Surgical Quality Improvement Program. Then we had the surgical date, the antimicrobial colonization allergies and data and others. Many factors can influence the variations in practice for surgical prophylaxis. Surgery is influenced by infection control in theater, the anesthetic practice, the infection control ward, the comorbidities of the patients, the length of the stay, and many other such factors. The reasons for the variations are the ownership of risk for surgical site infections, gaps in the evidence for prophylaxis, workflow, and the antimicrobial prophylaxis being considered as a low priority in surgical benevolence for individuals. The risk of prophylaxis is that a meta-analysis of the 44 random control study demonstrated that prolonged course of antibiotic prophylaxis had no benefit. The odds of not receiving the guideline concurrent prophylaxis were 6 times higher among those patients who developed infection with clostridium difficile infection compared to those who did not. Risk of prophylaxis, if you may refer to the article by Hubbard et al., it compared the effect of short versus prolonged perioperative antibiotic prophylaxis on surgical site infections and acquired antimicrobial resistance in a 4-year cohort study. And it was observed that after adjustment for possible confounding factors, prolonged perioperative antibiotic prophylaxis was not associated with any decreased risk of surgical site infections. It was correlated with an increased risk of isolation of Enterobacter instead. So the improvement practices is an imperative. Opportunities for surgeons to improve stewardship includes limit the perioperative antibiotics to the operating room, discontinue the use of topical antibiotics, have a fixed antibiotic duration after source control, limit the treatment for asymptomatic C. difficile infection, limit the treatment of asymptomatic bacteria, limit antibiotics for uncomplicated diverticulitis, discontinue antibiotics after appropriate incision and drainage. Improve the practices involves opportunities for practices can be achieved by clinicians including surgeons, nurses, pharmacists, and stewards. For example, if you see for the indication, is it needed all or is it still needed post op with drug? Regarding drug with the consideration of the colonization, screening, allergies, guidelines need to be considered. Timing that is going to be administered within 6 minutes prior to the incision and should be supported by evidence, and infection control should always be stringently followed, and doses should be correlated in accordance with the blood loss and long procedure or weight of the patient and other factors. Surgeon or anesthetic focused strategies should involve representatives from surgeries and anesthetics, joint team quality improvement projects, guide local surgical prophylaxis guidelines, involving key stakeholders at the facility, and surveillance and feedback of the program. Other strategies include the surveillance of the surgical site infection, develop a targeted action plan, circulate correspondence, display posters, and review what antimicrobial. The pharmac and the paramedics commonly using antimicrobials should be added. For example, for antibiotics, the time to pick serum is 10 to 20 minutes. Time to pick tissue is about 1 hour. 1 hour. The distribution is wide in the most tissue fluids. Protein binding is 84%. Elimination is up to 80 to 100% unchanged from renal. And half-life is about 1.8 hours. So the pharmac and paramedics needs to be followed while considering the prophylaxis. The clinical practice guidelines for antimicrobial prophylaxis surgeries, as mentioned, can be used as a base for formulating the surgical prophylaxis guidelines. It's published in the Journal of Health System Pharmacy for the year 2007. There may be similar other guidelines like ASHP, IDSA, SI, Surgical Infection Society, and Society of Healthcare Afterwards. The percentage of post-operative surgical site infection by the time of prophylaxis administration for nearly 28,000 patients undergone cardiac surgery were as follows. It was observed that continuing the surgical prophylaxis post these operative operations had no effect in the prevention of the infections. New antibody timing recommendations as of 2017 mentions start the antibiotic infusion 50 to 60 minutes prior to incision for beta lactams, and start the antibiotic infusion 60 to 120 minutes prior to incision for aminoglycosides like vancomycin, gentamicin, cefalox, leoflox, and azithromycin. You can refer to the resources for NPS medicine-wise antimicrobial courses for the same for the surgical antibiotic prophylaxis guidelines. The resources for an NSW Health mentions about the fact sheets and guidelines, developing the prophylaxis guidelines, auditing the how to audit the prophylaxis tools, using cause and effect diagram and process maps, and driver diagram templates for correspondence. Thank you for the references here used in this presentation.